In this video, we are going to be talking about the cervical spine. The first part of this conversation should really center around the cervical nerves. Understanding the anatomical layouts and relationships between the cervical nerves and their vertebral bodies and the intervertebral discs is really a high-yield concept. So the first place we need to begin is talking about where these nerve roots go in relationship to the vertebrae. Generally speaking, the rule you want to remember is that cervical nerves will exit above their corresponding cervical vertebrae, and this is true of every cervical nerve. The only exception is that the C8 nerve root will exit below the C7 vertebrae, and this should make a little bit of sense because there is no C8 vertebral body. There's no C8 vertebrae. There's only a C8 nerve root. And therefore, if you were going to follow the rule completely, including C8, there'd be no C8 nerve root to exit above a corresponding C8 vertebral body. So therefore, the exception to the rule is that C8, since it has to exit somewhere, it must exit below the C7 vertebral body. And if you're having difficulty conceptualizing this, let's just illustrate it on the slide. So in this example, I'm showing you 3 vertebral bodies and their intervertebral discs, which are shown in blue. You see C5, C6, and C7. Let's represent the cervical nerve roots in red. I'm going to label these for you in just a second, but see if you can test yourself and figure out which nerve roots these little red lines correspond to. You can pause the video if you want a second to think about it, but I'm going to go ahead and label this diagram now. Remember, cervical nerve roots exit above their corresponding cervical vertebrae. So you can see that the topmost or the superior cervical nerve roots shown on this diagram must correspond to C6 because they're exiting above the corresponding vertebrae. So it has to be above C6. And remember, the exception to the rule is that the C8 nerve root actually exits below C7 because, again, there's no C8 vertebral body, and therefore it can't exit above a vertebral body that just doesn't exist. So it has to go somewhere, and therefore it exits below C7. Now, this is what you want to remember, and the mnemonic to remember this is 7 up, 8 down. This mnemonic will remind you that for the first 7 cervical nerve roots, think up or exiting above the corresponding cervical vertebrae. And for the exception, for C8 nerve root, remember down. It will exit down or below C7. Now, why is this so important to understand? On COMLEX, on in-class exams, on whatever test you're taking where OMM may show up, it's pretty typical for test writers to give you a question where they describe some type of cervical spine pathology resulting in some type of cervical nerve root damage. Usually this will come in the form of an intervertebral disc herniation. So for example, look at the slide. If you have a leftward herniation of the intervertebral disc between C5 and C6, you can see that when that disc slides over, it will impinge upon the C6 nerve root. And then the question becomes, what type of sensory problem or motor problem or loss of reflex do you expect based on the fact that the C6 nerve root is having issues? So you need to know the clinical sequelae of a problem with any of these cervical nerve roots. So what does that mean that you need to know? You need to know the sensory distribution of these nerves, the motor distribution of these nerves, or the motor innervation, and the reflexes, if applicable, that these cervical nerve roots are responsible for. So let's start with sensory dermatomes. This is a map of sensory dermatomes. Basically, it shows you the areas of the body where these cervical nerve roots provide sensory innervation. What I want you to do if this seems overwhelming is to pay special attention to the hands, because if you look at the hands, depending on which finger you're talking about, which digit, there are 3 different cervical nerve roots responsible for that. So these are the ones you want to remember if you're feeling cramped for brain space and you think maybe you'll only be able to memorize a few. But for completeness sake, let's fill out this chart. So we're looking at cervical nerve roots going from C3 down to C8, and we want to be able to understand the sensory dermatome of all of these cervical nerve roots. So let's fill these in. The place to begin, I'm actually going to combine C3, C4, and C5. The reason I'm combining them is because these three cervical nerve roots, if you go back to this picture of the dermatome, you can see that C3, C4, and C5 all provide sensory innervation to somewhere around the neck, upper shoulder area, maybe slightly posterior aspect of the head, but it's mostly neck and shoulder area. So you can see that neck, shoulder, and superior chest. And the interesting thing about C3, C4, and C5 is that these nerve roots collectively comprise the phrenic nerve, which will refer gallbladder and diaphragm pain to the right shoulder. So if you're having true pathology in the gallbladder or the diaphragm, that pain via these nerve roots will be referred to the right shoulder. And again, look at the dermatomal distribution of C3, C4, and C5. You can see that they provide sensory innervation to not only that posterior head, neck, and chest and chest area, but it does go to the right shoulder as well. So that's the reason that via the phrenic nerve, you get that classic referred pain pattern. Now, as far as C6, C7, and C8, you want to remember the hand. I told you, if you're only going to remember one thing from this discussion, remember the dermatomal distribution in the hand. So C6 provides sensory innervation to the thumb. C7 provides it to the index and middle finger, also known as the second and third digit. And C8 will provide it to the ring and pinky finger, also known as the fourth and fifth digit. So if you have some type of nerve root impingement, usually in the form of intervertebral disc herniation, and that disc buds up against one of the cervical nerve roots and sort of knocks out or impinges upon it, you want to know how do I name that injury? And again, that will totally depend on which cervical nerve root is involved. But generally speaking, what I need you to remember and what I need you to take away from this discussion, because it's really high yield, is that when you have nerve root injury causing sensory loss or sensory dysfunction, we call that radiculitis. We refer to this as radiculitis. So let's do an example to make sure we're all on the same page. A 23-year-old baseball player suffers a throwing injury. He undergoes an MRI, which reveals a moderately sized leftward herniation of the C6 to C7 intervertebral disc. Which nerve root will be impinged by this herniation? All right, so let's go back to our diagram. Here is our vertebrae with intervertebral discs and cervical nerve roots. I'm telling you that there's leftward herniation of the C6 to C7 intervertebral disc. So this is what we're going to expect. That disc will slide to the left, and therefore it's going to impinge upon the C7 nerve root, because remember that C7 nerve root exits above corresponding C7 vertebral body. So that's the nerve root that's there to be impinged. So we know it's going to be C7. Now, part 2. If the patient were to experience paresthesias due to this injury, in what sensory dermatome would the discomfort be felt? All right, so I'm telling you that he's having paresthesia, so he's having abnormal sensation, maybe a little tingling, maybe a little bit of pain. Where do you expect that to be felt? Well, let's go back to our table. We know it's the C7 cervical nerve root, and according to this table, and what I told you is particularly high yield, it's going to be the index and the middle finger, the second and third digit, because that's the sensory dermatome that maps out C7. Left index finger and left middle finger, because again, it's the left herniation, so it's just going to be on the left side. Part 3, how would you correctly name this pathology? So this is going to be referred to as a left-sided C7 radiculitis. Left-sided because it's a left herniation, C7 because that's the nerve root that's going to be impinged, and radiculitis because that's the term that refers to abnormal sensory loss due to nerve root impingement. All right, so this is the table that you want to remember. But the truth is, guys and girls, that I didn't really give you the complete picture here, because in addition to just having to know sensory dermatomes, you also need to know one more thing about all of these cervical nerve roots. You need to know, if applicable, what reflex these nerve roots control. So the good news is that for C3 and C4, you actually don't need to know anything. There's no high yield reflex that you need to know. For C5 and C6, you want to know that these nerve roots help control the biceps and brachioradialis reflex. For C7 and C8, these will control the triceps reflex. So if you think about kind of your classic primary care physician using a reflex hammer to elicit a motor response, to elicit that reflex, and they're tapping on the biceps, they're tapping on the brachioradialis. These are the cervical nerve roots that are responsible for making that happen. And they're somewhat easy to remember because they go in groupings, right? C5 and C6 both do the same reflex. C7 and C8 both do the same reflex. So just remember this. Now, we mentioned that if there's loss of sensory, right, some problem with sensory, we call that radiculitis. But if there's loss of either muscular control or reflexes, that's a different term. That's actually called radiculopathy. So the itis is sensory and the opathy is muscle and reflex. So let's do another example. It's going to be similar to the example that we already did, but I'm just going to change up a few things. A 23-year-old baseball player suffers a throwing injury. He undergoes an MRI, which reveals a moderately sized leftward herniation of the C6 to C7 intervertebral disc. Which nerve root will be impinged by this herniation? So this is literally the same question as before. We've got leftward herniation of the intervertebral disc between C6 and C7 impinging upon the C7 nerve root. So just as it was before, you're knocking on the C7 nerve root. If the patient were to experience muscle fatigue and loss of a reflex due to this injury, what reflex might be hypoactive? Well, we know it's C7, so let's go back to our chart. The reflex that may be hypoactive is going to be the triceps reflex. All right? Lastly, how would you appropriately name this type of injury? This is a left-sided C7 radiculopathy. Left-sided because that's the direction of the herniation. C7 because that's the cervical nerve root that gets pinched in this injury. And radiculopathy because in this example, we're not talking about a sensory problem. We're talking about muscle fatigue and loss of a reflex or a hypoactive reflex. So again, if it's a muscle problem or a reflex problem, it's radiculopathy. If it's a sensory problem, so like tingly, pain, it's radiculitis. So the itis means sensory, the opathy means muscle and reflex. Memorize that. It's very high yield. Let's continue this conversation by talking about regional anatomy. So as far as the anatomy that you need to know in the cervical spine, there's really just a few things. First, the scalene muscles. There's 3 of them, anterior, middle, and posterior. And the highest yield thing that you need to know is just where they attach. This will be more relevant in the conversation we have about ribs. But briefly, anterior and middle scalenes, they both attach to the first rib. And posterior scalene, that muscle attaches to the second rib. Just try to memorize this. It'll be very important in a future lesson. The sternocleidomastoid muscle, the most important thing you need to know is the action of the muscle. So forget about the attachments. Just remember the action. The action of the SCM is side bend towards, rotate away, also known as STRA, S-T-R-A, side bend towards, rotate away. This is what happens when the sternocleidomastoid muscle contracts, but it's also what happens if you have a hypertonic SCM that's constantly contracting or over-contracting. And the reason this is really important is because you might have a picture where they show you torticollis, right? Someone's sternocleidomastoid is just way too hypertonic. And what it'll look like is what you see in this image. And based on the image they give you, you'll have to figure out, is it the right sternocleidomastoid that's hypertonic, or is it the left sternocleidomastoid that's hypertonic? And it's somewhat tricky because since it has that rotation away component to it, their head will be turned to the contralateral side. And if you look at an image and you see the head turned away to the contralateral side relative to the sternocleidomastoid that is actually the problem, it can throw you off and incorrectly make you think that it's actually the other sternocleidomastoid that's hypertonic. So just remember, you're going to see what this picture looks like. Side bending towards, shown with that blue arrow, rotation away, shown with that green arrow. And it's going to be in reference to the sternocleidomastoid that's actually dysfunctional. So if the chin is turned to the right, it's the left sternocleidomastoid that's going to be the problem. And it's because of that rotation away component. So very important to understand that. Now let's change gears and talk about cervical vertebrae motions. At each of the three parts of the cervical spine, there are three different primary motions. So as you might imagine, because there are three relevant portions of the cervical spine, and each of those three portions has a different primary motion, this is particularly high yield because test writers will just love to ask you this. At OA, the primary motion is flexion and extension. At AA, the primary motion is rotation. In fact, AA contributes at least 50%, if not more, of all of the rotation in the cervical spine. C2 to C7's primary motion is side bending. Now, how do you remember this? My mnemonic here is that the cervical spine is the first real segment, or the first real section, if you prefer that. But FRS for flexion, rotation, side bending, in order for your studying pleasure. Now, what about Fryette's laws? If you recall from our discussion in the fundamentals section, I told you that Fryette's laws only apply to the thoracic and lumbar spine. The reason for this is beyond the scope of COMLEX and frankly beyond the scope of what you even need to know for your in-class exams. But just for completeness sake, this has to do with the orientation of the facets and the way that osteopathic physicians can motion test these segments. So basically, when Fryette was formulating his laws, he determined that they could only consistently apply to the thoracic and lumbar spines. Now, despite that, even though the textbook answer is that Fryette's laws do not apply to the cervical spine, the way that we diagnose and name somatic dysfunction in the cervical spine still follows a pseudo version of Fryette's laws. So instead of saying that this segment is type 1, meaning it follows law number 1, Fryette's law number 1, or that this is type 2, meaning that it follows Fryette law number 2, we have to use a little bit different terminology, and that terminology is shown here on the slide. OA is considered to be type 1-like, which means that OA follows Fryette law number 1, not actually, but you'll follow that when you try to name somatic dysfunction at OA in the cervical spine. And likewise, from C2 to C7, that is said to be type 2-like, which means you'll use Fryette's law number 2, although again, the textbook answer is that this doesn't follow Fryette's laws, but you'll still apply the law to determine the direction of side bending and rotation when you're diagnosing somatic dysfunction. Let's talk about something that will aid you in doing just that. In order to get these questions right, you have to understand the concept of translation. Translation is a motion that the cervical vertebrae will kind of glide in one direction or the other. And usually this happens when you're doing your osteopathic structural exam. So you'll have the patient literally lying on the table. And on the slide, what you see is a depiction of the cervical spine while your patient is lying on the table. So imagine for the purposes of this discussion that your patient is lying on the table, they're lying supine, their head is closest to you on the exam table, and their feet are far away from you at the end of the table. And you're sitting at the head of the table and you're palpating their cervical spine as you perform your structural examination and you do motion testing. If one of their vertebrae are said to translate more easily to the right, what that means is that this vertebrae, here shown in the middle on this slide, slides more easily to the right. And the reason that the concept of translation is so important to understand is because when you have translation one way, it creates side bending in the opposite way, as you can see shown in this red arc. So as you translate a vertebrae more to the right, if it prefers to translate right, that segment is side bent left because it prefers side bending to the left, and you can see that evident from the red arc. So this is really high yield because if you think about it, on COMLEX, if they give you a question and they tell you which direction that segment prefers to translate, you can figure out side bending. And then knowing whether you're talking about OA and it being type 1-like or C2 to C7 and that being type 2-like, you would then apply Fryette's law number 1 or Fryette's law number 2, knowing what side bending is to figure out which direction rotation goes. And using that problem-solving formula, you can correctly name somatic dysfunction in the cervical spine. So very, very high yield. Make sure you understand translation, type 1-like and type 2-like. Let's finish up this lesson by just pointing out a few clinical pearls. These are things that have shown up on exams in the past, and therefore I do think it would be very prudent to know these bits of information. 1. Always treat thoracics or ribs before the cervical spine. Oftentimes, somatic dysfunction or musculoskeletal pathology just in general can originate in the thoracic or rib area and cause radiation up into the cervical spine. So you want to treat the thoracics first. 2. The alar or transverse ligament, both of those ligaments are weak in patients with Down syndrome and rheumatoid arthritis. So there are certain techniques that are actually contraindicated in patients with Down syndrome or rheumatoid arthritis, because if you accidentally tear one of those ligaments, which stabilize the vertebrae, you can cause really severe irreversible damage. In fact, it can be life-threatening. So those techniques will be contraindicated. More on that in a different lesson. 3. You need to take certain cautions when you perform any degree of cervical extension in the cervical spine due to vertebral artery insufficiency. So because of the way and because of the anatomy by which the vertebral arteries exit around the vertebrae, anytime you extend those segments, you're kind of putting a little bit of pinch on the vertebral artery. So if you're taking COMLEX or if you're taking an in-class exam and they give you a question where somebody is treated in some way with cervical extension, and then all of a sudden they get certain types of symptoms, you want to think about vertebral artery insufficiency. Lastly, let's talk about whiplash injuries. Whiplash injuries to the cervical spine are particularly severe, but there are two things that you want to keep in mind that are poor prognostic indicators. One is loss of the normal cervical lordosis. So normally the cervical spine has that nice curvy lordosis to it. But if somebody has a whiplash injury and then their C-spine on radiograph becomes more straight and they lose that lordosis, that is a poor prognostic indicator. And likewise, loss of consciousness at the scene of an accident, that's also a poor prognostic indicator. So if somebody is, say, the restrained passenger in a motor vehicle accident, and the fact that they're wearing their seatbelt causes that really severe whiplash injury, and then they lose consciousness, that loss of consciousness in and of itself is a poor prognostic indicator. So keep both of those things in mind, especially the loss of the lordosis in the cervical spine. And now lastly, finally, I know I keep saying we're going to end, but this is actually the last topic. We're just going to touch on the orientation of facets and the anatomical uniqueness of cervical vertebrae. So when you palpate a cervical vertebrae, you're not actually palpating the transverse process. If you're down in the thoracic or the lumbar spine, you're certainly palpating the transverse processes. But actually up in the cervical spine, what you're feeling are where those orange arrows are pointing. And those are actually articular processes, not transverse processes. And while we're on this topic, one of the really high yield parts of COMLEX is knowing the orientation of the superior facets. And you need to know the orientation in the cervical, thoracic, and lumbar spines. For whatever reason, the directions and orientations of these superior facets are very high yield. There's an easy way to remember this, and the mnemonic is BUMBLE-BIM. BUMBLE-BIM. B-U-M, B-U-L, B-M. Going down in order, starting at cervical, the superior facets are backwards, upwards, and medial in the cervical spine, backwards, upwards, and lateral in the thoracic spine, and just backwards and medial in the lumbar spine. I'm not going to include the facet orientations when we talk about the thoracic spine and the low back, so it's going to be here in this lecture. But just recall, BUMBLE-BIM, very, very high yield.